intrigued by his research interest in myocardial infarction and cardiac arrest. He and his team has revolutionized the concept of ECPR and take out of a hospital arrest straight to the cath lab. In his hospital, the door to ECMO time is about 6 to 7 minutes. Without further ado, please welcome Dr. Jason Bartos.
Thank you very much for having me, and I really do appreciate the invitation to talk about all of this and all of our work in Minnesota. I'm going to share my screen here. That said, there's a lot to talk about, as you mentioned, the ECPR program and patients and the overall critical care, and I'd love to talk about all of it. So if people have questions about any of that, please feel free to ask. The actual talk or the actual presentation will be mostly focused on therapeutic hypothermia in the setting of ECPR, because I think it is a unique patient population that defies many of the trials and maybe extends many of the trials that have been published in the world of cardiac arrest to an extent that it's worth discussing this patient population specifically. And so I'll be starting to talk about therapeutic hypothermia for the ECPR patient. I will present a little bit of our data from our program along the way, but please, again, feel free to ask for more if you have questions or are curious. So as many of you know, therapeutic hypothermia publications began long ago, now a decade or 2 decades ago. The HACA trial published in the New England Journal of Medicine with 273 patients, all with ROSC after a VF cardiac arrest, randomizing those patients between 32 degrees and 34 degrees for 24 hours. And that's versus normal, 32 to 34 degrees versus normal thermia. The primary endpoint was favorable neurologic outcome, and of course they showed a great benefit of hypothermia. And this really sparked a number of publications, as I will talk about and sort of walk through the progression as it gets us to today. But the important thing to note is, again, they were between 32 and 34 degrees in the hypothermia group versus the normothermia group. And the importance of control of normothermia becomes important with the TTM trial, as I'll talk about in a little bit, as a number of these patients, as you can see from the error bars, crossed the 38 degrees fever, official fever line, which makes many people argue that in fact they were not well controlled and allowed a number of fevers, which we do believe to be disfavorable for patients after cardiac arrest. So again, 2002, demonstrating a benefit of hypothermia in comparison to what they called normothermia in the study, and they showed significant survival benefit of the hypothermia with a survival rate around 60%, 65%, compared to normothermia that was just under 50%. Then came along Bernard, which only had 77 patients, also with ROSC in the field. These were not refractory arrest patients, as we typically talk about for ECPR, but shockable rhythms, randomized to 33 degrees for 12 hours, only 12 hours now, versus normothermia. And again, primary outcome is neurologically favorable survival. The temperature distribution shown here, they achieved the goal temperature pretty quickly within the first hour or so, and then they held that temperature for 12 hours and allowed it to rebound. That compared to normothermia. Now, while perhaps fewer patients were febrile here, some still were, and the average temperature was actually above the 37-degree normothermia line. They again showed a benefit to survival in those with the hypothermia compared to normothermia. So then came the TTM trial, as many of you are aware, 950 comatose patients with ROSC, again in the field, out of hospital cardiac arrest with any initial rhythm. So instead of the VF only groups that had been studied, this is now all rhythms, randomized to 33 versus 36 degrees for 28 hours and fever prevention for 72 hours to follow. So you can see that this is building on those previous trials where a number of patients did truly have a fever despite their normal thermia control. And they were very sensitive to that in this trial and ensured the best they could that there were no fevers. They had a number of interesting advancements in terms of trial design, where physicians were performing assessments and prognostication in a blinded fashion, which was an advancement. They didn't do any prognostication at all until 72 hours after they were admitted, which was again advancement. And the primary outcome was all-cause mortality here, with the secondary outcome being neurologic function or death. These are their curves. So again, 33 versus 36 degrees. You can see the average of the 36-degree group was at the 36 degrees, and the average of the 33-degree group was at around 33, perhaps a little bit higher. They might have been a little slower to get to goal than the previous studies. And when you look at the standard deviations here, they are not crossing that 38-degree fever line. So again, here they're controlling for fevers. Now, after the 28 hours, they do come up to 37 degrees in both groups, and there they may have a few patients that do start to cross that fever line. However, for the duration of the treatment period, the 28-hour treatment period, they were preventing fevers in addition. And as I'm sure you've heard, or most of you have, there was no difference in survival between these two groups. So the theory coming out of this trial was that it wasn't the hypothermia, it was the fever prevention that may be the key criteria or the key aspect of treatment that was improving the survival in those previous studies. So the other things though to think about, and again, these are important because these relate to our patients, the ECPR patients. So bystander CPR the rate was very high. In the United States, at least, unfortunately, we never reach levels like 73% for bystander CPR. We would dream of those rates, and then, despite lots of effort, we do not achieve that except for in some very select groups. Shockable rhythms in the TTM trial were still the predominant rhythm, and this, while they were including all rhythms, keep in mind that they required ROSC in the field, and of course shockable rhythms are more likely to achieve ROSC, and so it was still a predominantly shockable rhythm study. The median time from arrest to BLS was very short, about 1 minute, and their overall CPR time was 25 minutes. So I will show you in our data where our ECPR patients are receiving CPR for an average of an hour, and there again, our time from arrest to BLS is at least 5 to 10 minutes. So all these things together really do differentiate our ECPR patient from the typical TTM patient. This trial just came out last year, 2019, looking at non-shockable rhythms specifically. And this is interesting, one, because of the very specific look at non-shockable rhythms and the relatively low survival rates in both groups, but also in the outcomes, which I will show you momentarily. This is their control, or their temperature control graph. Basically, their 33-degree group was truly 33 degrees. But there was such a range across their patients that the 37-degree group, again, had a number of patients with fever in that arm of the trial. These are their neurologic outcomes, and if you look at the hypothermia group, all the way to the right in the, I don't know if you can see this arrow, but all the way to the right is this yellow box, 5.6% with a CPC score of 1. The orange box here is CPC score of 2. So those together being minimally impacted neurologic scores, well over 10% overall in that neurologically favorable group compared to 5.5% or so in the normothermia group. So again, in non-shockable rhythms specifically, and you notice that the percentages are low, 10 versus 5%, but still a significant benefit of improved neurologic function or neurologically favorable outcomes in patients who received hypothermia in this study. So now getting into some of the sub-analyses and the analyses of the sub-analyses. So these studies help us get into some of the additional theories that come from the TTM trial and additional targeted temperature management trials after that time. So this is a study from Dr. Calloway looking at almost 2,400 patients in Pittsburgh treated between 2010 and 2018. 490 or so received 33 degrees and 422 received 36 degrees. Notably in this study, all rhythms were included. Only 27% of them were shockable patients. There were some in-hospital arrests as well in this group, so it's a mixed bag in many ways in terms of the patient population here. This is the overall survival and neurologic outcomes for them. So if you look comparing 33 to 36, the overall survival is similar, 25% in the 33% group versus 29% in the 36-degree group. If you look at the MRS and CPC scores, the MRS scores have about the same number of patients in 0 through 3 compared to the 36-degree group. If you look at the CPC group, you can start to see a differentiation in class 1 and 2, 24% versus 21% in the 36-degree group, but still not significant as an overall group. Where this is interesting, and the purpose of this study was really to look at the theory that the TTM trial had a lot of patients that were not very injured. Effectively, because of those very short downtimes and because of the very high bystander CPR rate, the patients largely came out without much of a neurologic injury to begin with. And if you believe that, then it's possible that the benefit of therapeutic hypothermia may not have been very great in that population because there wasn't much benefit to provide. And that was one of the key criticisms, because they did have such an efficient response to these patients and relatively short CPR times, that perhaps if you looked at those that were very severely injured, you would have more of a differentiation between the two groups. And really, you might see, the hypothesis of this study was that you might see a benefit of hypothermia in patients that are otherwise sicker when they arrive to the hospital. So that's shown here. So the PCAC score, the post-cardiac arrest category score, a Pittsburgh developed score, really assessing a patient's overall sickness after a cardiac arrest when they arrive. And then the low scores are good, high scores are bad or sicker. So if you look at the overall, again, for the total number and percent surviving, it's 35 versus 40%. However, as you march up the score, of course, fewer survive, but more survive in the 33-degree group. So PCAC4, the sickest of these patients, the 15% survival overall in the 33-degree group versus 5.4% in the 36-degree group. And you can see the risk ratios increasing, or the relative risks of survival increasing over time with the higher sickness of those patients. This again suggesting that perhaps those patients who have the most injury in a cardiac arrest benefit the most from low temperatures. This also, if you look at, instead of just overall survival, you look at specifically CPC 1 to 3, looking again at neurologically favorable survival, you see essentially the same trend. And it is statistically significant, where people that come in PCAC4 have a 13% chance of coming out neurologically minimally injured compared to 4.7% in the 36-degree group. Now, this is again a sub-analysis of the TTM trial. So this is the same data where no benefit was demonstrated between those two temperatures. But now that you separate out these really sick patients, you start to see some differentiation. So the difference between intravascular cooling and surface cooling. Now, for me, as a person who's connecting my patients to an ECMO circuit, I'm functionally delivering intravascular cooling as soon as they're on that ECMO circuit. The ECMO itself, because it's passing the blood outside the body, does provide functionally intravascular cooling. Now, I will show you multiple aspects of the intravascular cooling that are important. One is the cooling itself, and the second is the precision and the way you can control it. My setup with my ECMO circuits and my machines do not provide very precise control of the temperature for these patients. So what you will see, and what I will happily talk more about as we go on here, is the way we control the temperature. We do use the Thermogard temperature control system from ZOLL. We use that catheter for two purposes. One is to control the temperature in a very precise way, and the second is for vascular access. It's a triple lumen catheter, so that provides us the access we may need for pressors and sedation and everything else in a very sick patient population. But I will show you some data first, and then I'll show you data from our program. So intravascular, again, versus surface cooling. This paper came out in 2016, looking at the precision achieved in the TTM trial, comparing the, again, 33 versus 36 degree groups and their ability to control the temperature in the top here 33 degree group, in the bottom 36 degree group, using intravascular or surface cooling devices. The specific device used in that trial was not predetermined. You could use what your hospital had. And so for these patients, some got intravascular cooling, some received surface cooling. And when you look at the overall trend, basically those error bars in the sort of shaded area and then the lines being the means, the intravascular cooling at 33 degrees is much tighter than the surface cooling, and at 36 degrees it's less different, but it still is a little tighter and better controlled. And again, in a trial where you may choose in the future, if they do another trial of these temperatures and they choose 37 degrees, being able to precisely control that temperature to still prevent fevers is very important. When they looked at different characteristics that actually teased out a benefit or a difference between the intravascular and surface cooling, that's shown here. So there was actually no significant difference in time to target temperature or maximum cooling rate between the two devices, or the two classes of devices. It still didn't specify which device would be used in each category either, but lumping together all intravascular and all surface cooling is what's shown here. So the number of patients achieving temperature, the goal temperature, within 4 hours was not significantly different. The number achieving temperature ever was not significantly different. And the episodes of overcooling were not significantly different, though that strongly favored intravascular. It was not significant. When you start looking down at this graph in the bottom left, you start to see some differences. So cumulative deviation out of range, again, the precision of that temperature hold was significantly better and tighter in intravascular or with intravascular cooling. The number of patients out of range at all also better with intravascular cooling, and the number of times out of range better with intravascular cooling. So functionally in this study, when they looked at the data, it was the precision of cooling was much better with intravascular than it was with surface, or at least significantly better with intravascular. Whereas the other characteristics, the ability to get a patient to cold temperature and some of the other sort of lab-based anomalies like shivering, hypokalemia, hypophosphatemia, hyperglycemia, those were not different. But the ability to control that temperature was significantly better with intravascular cooling. Okay, another study published again last year looking at the TTH-48 trial and comparing intravascular versus surface cooling. Again, similar thing here. Now, as you may have guessed from the name of the trial, the TTH-48, it compared 24 to 48 degrees, or sorry, 24 to 48 hours of cooling. And so this really gets to the question of, can you control the temperature for a long duration of time? And what happens later on in the time course. So looking at the 24 hours in the top figure, they both achieved the goal temperature quickly, and then they were both able to hold it. But what you'll notice again from the size of the error bars is that the intravascular cooling was much more precise in the ability to control that temperature, and then also much more precise in its ability to control the rewarming. Whether that's important, we don't really have good data to say what time or what rate of warming is best, whether the precision is important, but I think logic says it probably is. We just don't know for sure. We'll need more studies to demonstrate that. Interestingly, when you look at 48 hours, so at least in the United States, we typically do 24 hours. I'm curious as to what you would typically do in Japan, if there is sort of a typical timing that you use in the country of Japan, probably some variability. But in the United States, typically, we're 24 hours. The 48 hours was pretty interesting in terms of its ability to maintain that temperature out to the 48th hour. Now, there is a component of this, which is there are people where they had to start rewarming early because of hemodynamic compromise or some other aspect. Usually it's hemodynamic. or some start to move toward withdrawal of care, actually. But still, hemodynamic compromise and bradycardia are the big things. And so there is a lot of variability. So why there would be more variability in the surface cooling group, if that's the reason for it, and we don't know if that's the reason for it, but if that is, it's interesting, and it suggests perhaps the surface cooling had more of an effect that needed to be mitigated by earlier rewarming. I don't know the answer to that, and nor do the people who did this study. But the ability to maintain that precise cold temperature with intravascular cooling all the way to the 48th hour was something that the intravascular cooling definitely achieved better than the surface cooling, as well as that much more precise rewarming, which we had talked about before. Now, the outcomes in that study, the TTH48, if you separate them between intravascular cooling and surface cooling, there are no significant differences between those two techniques for mortality. So off the top, there are no significant differences. That said, there is a trend in each category where mortality is lower in the intravascular cooling group in almost every subset, not all. But if you look at all patients, there's a trend. It is not significant, and the p-value is not very close to significant. If you look at the 24-hour group, it's actually either no trend or it's reversed a little bit. If you look at those people who receive 48 hours, mortality overall at 48 hours was a little bit lower than 24 hours, and there was more of a significant benefit or significant change in the intravascular group, albeit not statistically significant. Again, there were no statistically significant differences in these groups. One of the reasons for that may be that they were relatively small. By the time they differentiated out all these subgroups, they only had 114 patients in the intravascular cooling at 48 hours and 61 patients in the surface cooling at 48 hours. So it's difficult to show statistically significant differences with that small number of patients. But that said, there were trends, but nothing statistically significant. And if you look at neurologically unfavorable outcomes, those unfavorable outcomes were higher with surface cooling in all groups, but again, not statistically significant. And it did, if anything, stretch that benefit going for 48 hours, suggesting that, again, that lack of control in the full 48 hours might be playing a role in that. But again, a lot of that is conjecture because these are not statistically significant differences. The time, these are some important sort of variables down here. The time to goal temp was technically shorter with intravascular cooling by about half. So they were able to get down to goal temperature within 2.2 hours versus 4.2 with surface cooling in this study. The temperature variability was lower. Again, that precision of temperature control was lower with intravascular cooling. The rewarming rate variability, which you could see in that graph, the control of rewarming was better with intravascular cooling. And there were no significant differences, again, in mortality or neurologic outcomes between the two groups. This study, also published in 2019, did show a significant benefit, but it was in a very specific subgroup. So this is a retrospective study looking at 161 propensity-matched patients out of a cohort. So this is a retrospective study of a single country cohort from these authors. And they looked at a bunch of different subgroups, and what they found is basically a significant improvement with intravascular cooling in patients who are more than 65 years old. So if you look at the outline box down here in the lower right, those are the odds ratios for those different characteristics, and age down in the bottom, or sorry, intravascular cooling was significant, 0.02 p-value in the elderly group, and by elderly, age greater than 65 is how they classified that. So this is the first group that had shown a benefit of intravascular cooling in a hard outcome like odds ratio for mortality or for survival, but again in this subgroup. Now, why in this subgroup? Perhaps you could argue again that this subgroup would do more poorly during a cardiac arrest. They would be sicker because of their age and their less resilient status, but that's again all conjecture. This is just something they had observed. Now, there's a very nice systematic review published this year in the journal Resuscitation from Bartlett et al., looking at 12 studies comparing intravascular cooling to surface cooling. And this gets into a lot more detail. But if you look at these 12 studies. None of those studies individually showed a benefit in survival, and as a group, it almost is significant, but barely. It just barely crosses the unity line between intravascular therapeutic hypothermia versus the surface cooling. That said, it favors the intravascular cooling, and that's overall survival. If you look at good neurologic outcomes, it's statistically significantly favored toward intravascular cooling. So in those 12 studies, again, no single study except for the one from O showed a significant benefit in good neurologic outcomes with any method of cooling. But when they're all put together in this meta-analysis and systematic review, they favor the intravascular cooling, perhaps because of the increased precision, perhaps because of speed of cooling. So many factors, as I've been talking about, that might relate to that outcome and why there would be a better outcome. Yet, in the end, what we know is there's a better neurologic outcome with intravascular cooling. So our protocol at the university, I'm bringing it back a little bit to the patients, these ECPR patients. So our program is an out-of-hospital cardiac arrest oriented program where we bring all of the patients to the University of Minnesota to the cath lab where we cannulate them for ECMO. So we ask our paramedics, our pre-hospital emergency medical services providers, to select patients based on the criteria on the left in this box. Patients with age 18 to 75, shockable rhythms only as the presenting rhythm. They can be shocked into PEA or asystole and they still qualify, but they cannot start with PEA or asystole when the paramedics arrive. If they're in continuous ongoing VF, we ask them to try at least 3 shocks and a dose of amiodarone, 300 milligrams of amiodarone, to declare them refractory. We ask that all patients can be fit within a Lucas device to prevent injury to our paramedics when they're driving the patients to the hospital. And then we also ask them to estimate the travel time from the scene to the hospital and primarily bring the patients to us only if that travel time is less than 30 minutes from the moment they leave the scene to when they arrive at the hospital. Now, through this work, I will say that I have found that paramedics, our pre-hospital EMS providers, are very optimistic, and the travel time is often longer than 30 minutes. However, that is what we ask them to select for. We do exclude patients who have a DNR or DNI status if they have a known terminal illness, like terminal cancer, some other some other illness where life expectancy would be expected to be less than 1 year, nursing home residents, or people with severe trauma and bleeding, which would be the non-cardiac etiology. If the paramedics feel that they meet those criteria, they call us, activate our cath lab, so that we're ready for the patient to arrive, much like we treat STEMIs in the cardiac cath lab or acute MIs in the cath lab, where we activate the cath lab and have the staff waiting for the patient's arrival. We do the same thing for these patients. They come to the hospital, we put them on the cath lab table, we get access, and we draw a blood gas, looking at the blood gas in 2 ways. One is the PaO2. We want a PaO2 of greater than 50 millimeters of mercury if we're going to go on ECMO. And the way it's written on this table is the resuscitation termination criteria. So if the PaO2 is less than 50, we terminate the resuscitation and do not place them on ECMO. If the lactic acid is greater than 18, we terminate the resuscitation and do not put them on ECMO. If the end-tidal CO2, as measured by the paramedics on arrival to us, is less than 10, we also do not put them on ECMO. But of all of those criteria, we have never had a patient with an end-tidal CO2 less than 10. And the reason for that is, if anything, our patients are hypoventilated, and the PaCO2 is 100 to 120. And if it's that high, it's very hard to have an end-tidal CO2 less than 10. If they do not have one or more of those resuscitation termination criteria, we go ahead and place them on ECMO. And we do that using ultrasound guided access, using fluoroscopy, as we would in the cath lab with any other patient, any other STEMI patient. We use 25 French venous cannulas and 15 to 17 French arterial cannulas. We do an angiogram, a coronary angiogram for all of the patients. We do PCI on the spot if if it's indicated, if they have a severe critical coronary lesion, or if they have a obvious culprit lesion, we will PCI those lesions. We put in an antegrade flow cannula in the same leg that we placed the arterial cannula for the ECMO in the superficial femoral artery. We may place a balloon pump or an Impella or a pigtail catheter for LV venting if we feel that they need it. And we can talk about how we govern or how we decide that more, but it is up to the discretion of those of us doing the ECMO for that specific patient. We don't have set criteria, but we have some general guidelines. We place a right radial arterial line and the ThermoGuard for the therapeutic hypothermia there in the cath lab. So if you picture the patient, typically we put the arterial and venous cannulas in the same leg, in the femoral artery and femoral vein, usually on the right leg, because we're interventional cardiologists and we start with the right leg. We then put a sheath in the left femoral artery through which we do the coronary angiogram and the PCI, and we may use that same sheath, exchange that out for the balloon pump or pigtail, and then we put a sheath in the left femoral vein, and then use that initially for medications to resuscitate the patient, and then when we're done with everything else, we swap out that sheath for the ThermoGuard. So we have bilateral femoral arteries and bilateral femoral veins occupied with catheters or cannulas, and the patient goes up with those. We do not automatically put anything in the neck. We can do everything we need with femoral vessels. Now, once we've done all the resuscitation that we can do and we have the PCI performed and we've given them all the medications we can treat them with, the clock begins and we wait for 90 minutes trying to get the person into an organized rhythm. We have had about 10% of the patients where we cannot get them out of VF. In that case, those patients die in a cath lab. The majority, though, 90%, will come out of VF, either because we've fixed their coronary disease or because we've treated them with the right medications in addition to the flow from the ECMO. Whatever the right recipe is, we are able to get them out of VF and then they get admitted to the ICU. And so an example just from the other day, from Sunday, I had a patient come in from the pre-hospital setting, driven in, 55 minutes of CPR on arrival. Within 3 minutes, we had the patient on the table, the blood gas had access in the artery and vein and had the blood gas done. So I knew at that point that his PaO2 was in the 80s, I think it was 85, 86, and his lactic acid was 13. So proceeded with cannulation. He was on ECMO within 6 minutes of his arrival. So it took 3 minutes from that point to get ECMO started. Looked at his coronary arteries. He had horrible coronary artery disease. Throughout, he is only 54 years old, and yet he had very, very bad disease. His RCA, his right coronary artery, had a 90% lesion down the entire stretch of the proximal and mid right coronary artery. His left main coronary artery was 99% stenosed. His LAD for the entire proximal and mid portion was 90% stenosed. Miraculously, he had a relatively normal sized LAD after all of that disease, and his circ was only about 75 to 80% stenosed for the entire distance of the circumflex. So I stented his left main all the way into the LAD, did the proximal optimization for the circ, but did not fix the circ and did not fix the RCA because he had TIMI3 flow down those vessels. We honestly don't know what the right answer is for which vessels to fix, but our rule of thumb at this point is that we fix the critical vessels, the one that we think are the culprit, and we try to avoid fixing all of the rest in a situation like this because of the large amount of contrast that I would be flooding him with to do all of that. So he had then LAD function or LAD flow it went from TIMI1, which is what it was beforehand. If there are any interventional cardiologists listening in, TIMI1 makes sense. If you're not an interventional cardiologist, it probably doesn't. TIMI1 is TIMI flow is a measure of how many beats of the heart basically it takes to get contrast from where it leaves the catheter down to the distal part of the vessel. TIMI1 is very slow, requires many beats. TIMI3 is normal, usually a beat or two, the blood will flow right down, and TIMI2 is in the middle. So TIMI1 flow is very slow flow, trying to get through all of those blockages. And after the stents, he was back to TIMI3 flow. Everything was back. Now, when he came in, I mentioned I got him on ECMO in 6 minutes. As soon as he was on ECMO, let the dust settle, made sure all the cannulas were secure and in place where I wanted them, and then I gave him 2 shocks. He was still in VF. He could not come out. Even with ECMO flow, he was still stuck in VF. We had anesthesia come and intubate him because he had a supraglottic airway from the field. So that was before I even looked at the coronaries. We got an airway in him. They gave him propofol for that just to make sure he was comfortable, and they gave him paralytic. After all of that medication, hoping that maybe the medication and a little more time of perfusion would help, I shocked him 2 more times. Still no capture. He's still in VF the whole time. Then I fixed the coronary, fixed the left main and LED. 1 shock, he was back out into sinus rhythm. So really, in his case in particular, it's a great demonstration of how that patient in VF the entire time was not going to come out of VF until I fixed his coronary disease. Even with complete normalization of flow with the ECMO, still I was not going to be able to get him out of VF until his coronaries were reperfused and his heart was reperfused. And that, as you know, if you're doing ECPR, one of the benefits of the ECMO is that it provides such great stability that you can fix left main coronary arteries, these extensive lesions all the way down an LAD when it's sort of bordering on a chronic total occlusion, because now you have the stability of ECMO to do that. Doing that with ongoing CPR is very, very challenging. So he's right now, this patient's now in the ICU. He's recovering, his lactate's normal, went from 13, as we normally see actually when we first start the ECMO, we circulate all the blood a whole lot better and our lactate often goes up before it comes down. We're circulating lactate out of these tissues where the lactate was sequestered. So it went from 13 to 15 and then came back down. His lactate's now normal. He's been rewarmed now today, or he's rewarming today. And so he will hopefully do well. I don't know yet, but we'll find out. I'll let you know when I find out. This is data from our first 160 patients. So this just was published January of this year. So the 160 patients was through about September last year. And so if you look at our first 160 patients, 17% of them did not meet, or they met one of those resuscitation termination criteria, meaning that in 17% of the patients, their PaO2 is less than 50 or their lactic acid is greater than 18. And you can see that 20 of those 27 patients, the ABG PaO2 was the problem, whereas in 7 of them, the lactic acid was the problem. So 83% of the patients went on to get the full treatment. 8% of those still did not get an organized rhythm after 90 minutes of doing everything we could, including opening up the arteries, revascularization, all the medications we could throw at them, still could not get them out of VF. So that 8% died in the cath lab as well. 76% of the total patients that arrived were admitted into the ICU. If you look at all the patients that received the full treatment, so that's 133 patients, 39% of them left the hospital neurologically intact. So 39% compared to what we believe to be 0 to 5%. And I will say that we believe to be because we don't have a randomized trial that's yet been published, but we do have the ARREST trial, which we've performed here in Minnesota and is now complete, and we hope for publication in the next couple months. The ARREST trial is truly a randomized trial, randomizing patients between ECMO and standard of care ACLS. And so when that comes out, I hope you guys will find it interesting, but we will finally have a few answers. One is, what does standard of care really deliver in this patient population in terms of survival? I bet it's pretty low. And then also, what benefit in a randomized study does ECPR provide? And I bet it's pretty good, but we'll have to wait and see. The characteristics for these patients are on the right, and this you do have to keep in mind, especially when it comes to race, that this is a Minnesota population. So Minnesota is an upper Midwest state in the middle of the United States. We have somewhat lower racial diversity than other areas of the United States. And so the age range on these patients on average is 57 years. The majority of them are male, and that's because we think because of the coronary disease as the primary etiology, and coronary disease is more prominent in the male population. The vast majority of our patients are white because of our geographic location. 76% of them were witnessed arrest. 66% had bystander CPR, and 35% arrested in a public location. The average duration of CPR, meaning from the arrival of those paramedics to initiation of ECMO, was 60 minutes. So very long CPR rates, and much longer than what you saw again in the TTM trial and these other trials where they had mostly patients that had ROSC, because patients don't tend to get ROSC after 45 or so minutes of CPR. So this long duration CPR is unique to the refractory population and suggests that the previous therapeutic hypothermia trials may not relate directly to our patient population. That said, the study from Dr. Callaway that was just published does, I think, more directly address this population, because this patient population is more likely to be in that highly sick group where therapeutic hypothermia was even more important and did start to show a benefit compared to the normothermic group. Again, this is what we use, the Thermogard machine and the Quattro catheter, the one that's shown here. And again, the two benefits that we have, one is we can control the temperature, and the second is that we have the 3-lumen access, so we can deliver all the medications we need to deliver. So this is our data using that catheter. And again, 100% of our patients get that catheter. So I don't have a comparison group between this and surface cooling. This is just what everybody gets here in our program. And you can see that it's about the same precision. So we target as our goal, this is 145 patients in this group, and the goal is 34 degrees. We chose 34 degrees intentionally, but somewhat arbitrarily. And I will freely say that we don't know what the right answer is in terms of the goal temperature in this patient population, but we basically said the acceptable range is 32 to 36, as governed by the guidelines. 32 and 33 were a little concerning to us because we have to anticoagulate our patients on ECPR, and so we are worried about bleeds at the really low temperatures. At the same time, we did think our patients are more severely injured than the average TTM trial patient, so 36 seemed too high or too normal of temperature for us, so we chose 34. But again, I freely admit, I don't have data to guide that decision. We, like most in the United States, we hold that temperature for 24 hours. So what you can see is there's a slow and steady, very minimal increase over time in the averages. The reason for that is we do have some patients that are bleeding profusely because of some issue with CPR trauma, typically bleeding into their chest or some other location. And so we do have to rewarm people a bit early, and every minute that goes by or every hour that goes by is another hour that somebody may need to be rewarmed a little bit early. So the average does creep up, but in general, we're pretty close to 34 degrees. Again, 1 degree, this 34 to 35 degrees, we're much closer to 34 degrees. Very few patients need to be rewarmed early, and our precision is very tight. So we're 34 plus or minus a degree basically for the entire time. These are standard deviations. So we have very high precision with this method of cooling and with proceeding on. Now we do, if at all possible, maintain normal temperature with the Thermogard for another 24 to 48 hours to prevent fevers. So you'll see for ours, similar to what the TTM trial did, we try to clamp that temperature even after the fact and make sure there are no fevers even when we're at 37 degrees. Now, the interesting thing here, and why one of my residents, my internal medicine residents, will be presenting this at the Resuscitation conference in the fall, because he looked at the initial temperature. So this graph, why it's separated into those who survived in blue and those who went on to die in red, is this part, and that is that we see that low temperatures as the initial temperature are bad. And the reason for that is basically it's a pretty direct correlation to the severity of the arrest. How long were they getting CPR? How long were they basically not making their own energy and their own heat? So they were just losing heat to the environment and slowly cooling over time. The other thing that differentiates this population, the ECPR population, compared to the TTM trial or the TTH48 trial or the HACA or the Bernard study, all those studies, if you remember, start at a high temperature, or start at a relatively normal temperature, like 35 degrees, maybe 36 degrees, and then they cool them. And one of the key criteria in those studies was how quickly they can get to the goal temperature. What you'll notice here is that our goal temperature, granted, is 34 degrees, but most of the patients are already there when they get to us. After 1 hour of CPR, they are already at that temperature. And so we do not use the Thermogard catheter or the ECMO circuit to cool them. We use the devices to maintain temperature and to prevent rewarming, and also to prevent further cooling, because when you've had CPR for an hour and you're really sick, you still aren't producing much heat even after the ECMO, and they can drop their temperature even lower. So for us, it's all about the precision of that temperature and trying to maintain it at our goal, which again is 34 degrees for this population. We could just as easily try to control the temperature at 33 degrees, in which case, for many of the patients, we would have to drop them by a degree to get them to that goal. But it works very well, and it's very tightly controlled. And while again, we don't have great data for the role of that in survival in ECPR patients, because there just aren't many studies yet on ECPR patients in this category, we do have data, as I've been discussing, from the patients that have ROSC, that perhaps those characteristics of this cooling technique can actually improve survival, at least in those patients who are very sick, which is absolutely the ECPR patient population in general. So to put all of this together, so comatose patients with ROSC after cardiac arrest seem to benefit from temperature control. This is TTM trial saying we're going to control that temperature and prevent fever. People seem to benefit from that, and if you extrapolate to the Haka and Bernard trial, perhaps cooler temperatures are better, but at least controlling the temperature and preventing fever is beneficial in all of those patients. Hypothermia seems to specifically benefit patients, at least more dramatically, in those patients who have severe injury. That's again Dr. Calloway's study showing in the sicker patients that they have better outcomes with hypothermia, 33 degrees. Intravascular hypothermia provides us improved precision and the control, which may lead to improved neurologically favorable survival. And again, some of those studies, the sort of sub-studies, are showing that direction in terms of improved neurologically favorable survival. It's likely that ECPR patients are going to be the patients that benefit the most from hypothermia because they are so severely injured, but we really do need some more studies looking specifically at that population to demonstrate that. And ECPR patients definitely need the precision for control and rewarming more than cooling, because again, they do come in a little cooler, but also the temperature that can be lost through the ECMO circuit does require that you have some other method of clamping that temperature and make sure that they don't change much to really maintain that precision. And that's, again, why in our program, from the beginning, we use the Thermogard to maintain that precision. So that's the data part and the presentation part. I very much thank you for your attention. Really appreciate the invitation to talk with you all. That said, I am happy to talk more about the data. I'm happy to talk more about our program, or really anything else that you find curious or interesting. Please let me know what questions I can answer for you. Thank you so much.
Thank you, Dr. Bartos. Let's open for some questions. I saw one question through the chat. Do you use a sedation or paralytic?
Good question. So there are a lot of different methods. I'd be curious to know what your teams are using for that as well, because there are so many different ways to go about it. So we use paralytics, and we tend to use cisatracurium as our paralytic of choice. It is more expensive for us, at least, and that can be a bit of a problem. But the nice thing about cisatracurium is that it's metabolized in the bloodstream, it's metabolized quickly, and so when we turn it off, we know it goes away in a few minutes, as opposed to vecuronium or rocuronium, where you may have it hanging around in the bloodstream for a long time in an ECPR patient where their kidneys and livers have stopped functioning. And so your normal metabolic pathways are very dysfunctional. Now, we do also use sedation, and we try that as the first line, but where we differentiate from some groups is in our sort of prolific use of paralytics. For sedation, we typically use Versed or midazolam, and that's also a debated topic. Some people swear by propofol, Others say propofol is horrible, and you can build different arguments for whether, and you can go down to basic science and discuss mitochondrial level mechanisms for why it would be good or bad. You can basically build an argument for either one. And we don't have a lot of data to help us guide that. So it's really in a theoretical argument phase. So we don't use propofol. We use the Versed to just stay clear of the debate and use midazolam instead. The issue with midazolam, which I will also freely admit, is that midazolam does hang around for a long time, and especially in people with kidneys and livers, which are not very functional. So we do have to wait a substantial period of time to allow these patients to wake up to know if the midazolam and its metabolites have all cleared the system. And that's one of the limitations of our approach. We just have to be patient. Propofol would be nicer for that, but still, I worry about the debate and which side is actually right. So we avoid the propofol. So we sedate first. If we still have shivering, we do give paralytic. That said, with the combination, at least, of the ECMO circuit and the ThermoGuard, we really don't have an issue maintaining our goal temperature or achieving our goal temperature despite shivering. So for us, shivering is not a limitation to the hypothermia. Shivering is more for concern for patient comfort. And that's why we treat shivering in our patients. So, I think the reasons to treat shivering are many. The big one is usually because you can't get to the goal temperature. That is not our problem in our patients. But certainly people worry about the comfort of the patient, and certainly when the families are seeing their loved one shivering away, it can be very disconcerting. So we do give them a little treatment just to help them stay free of the shivering. Very good question. Thank you.
So here's another question via the chat room. What is your most difficult part to initiate hypothermia? Oh, okay. Is that what is the most difficult part? Yeah.
Okay. So for the hypothermia, again, there aren't many difficult parts for initiating hypothermia for ECPR patients on ECMO because they come in cooler. You have an ECMO circuit that will drive their temperature down as well, and you have the potential to use as we do, an intravascular cooling device like the ThermoGuard catheter to maintain that temperature and control it. So for us, achieving hypothermia is easy. Now, we do have patients that are not included in any of the data that I described from our institution that don't require ECMO, non-ECPR patients who achieve ROSC in the field. There, it can be a little more challenging because you don't have an ECMO circuit. So we still very much use the ThermoGuard catheter in those people to pull down their temperature because they don't come in as cold as the ECPR patients. We need to actively cool them. And there, it can be a little bit challenging if they don't come through the cath lab, just mechanically and logistically to get them on the machine at our institution. But functionally, it's the same. It's still just like placing a central venous catheter in the femoral vein, putting that Quattro catheter up, and the Quattro has the ability to remove a lot of heat quickly, so we're able to achieve the temperature very easily, especially with some sedation.
Any questions from the Japan side of? I know there's two simultaneous of interpretation. Any question from other side? Okay, nope. Okay, I'm going to ask two questions, Dr. Bartos. One is for non-ECPR patient, do you use a target 34 or 33?
We still, because we don't want to confuse our staff, we still use 34. Okay. I will say that I think I'm warming to the idea that it's better to be cooler. So I think that we, over time, may move closer to 33 or even 32 degrees for patients, and then hold them there. Still, we have, like I mentioned, we do 24 hours of cooling. I'm also warming to the idea that longer of cooling is better. So it's possible that we may do 48 hours in the future, or a slower rewarming phase. But right now, if you just came to my ICU today, we would be doing 34 degrees for all of our patients who achieve DROSC in the field as well.
Okay. My second question is, you mentioned when you use ThermoGuard with ECMO together, mainly is for maintain at the target temperature and rewarming. So what is your rewarming rate?
That's a good question, because a lot of places do things very differently. So our rewarming, our foundation program or protocol for rewarming is 1/2 degree, so 0.5 degrees per hour. That's the fastest that we rewarm, and that's the standard at our institution. Now, if anybody has any sense or any hint of cerebral edema, and we do head CT for all of our ECPR patients, as soon as we're done in the cath lab with everything we're going to do, as we're moving toward the ICU, we go right through the CT scanner and get a head, chest, abdomen, pelvis CT scan to look for trauma and signs of injury. So if we see any signs of cerebral edema or anoxic injury on that initial head CT, I will rewarm much slower. So I often rewarm at 0.15 degrees per hour for those people, where I want to be very gentle and reduce the amount of reactive edema I may get as I'm rewarming them. But our standard, again, is 0.5 degrees per hour.
Okay. Any questions from anybody want to ask directly? Like I said, you can ask. Okay, here's one question via the chat room. Is there a possibility that the placement of a cooling catheter and ECMO venous catheter in the same place cause a problem? The balloon can interfere with the blood input to venous cannula, and if the balloon itself can be sucked into the side lumen of a venous cannula.
It's a very good question, because you have limited real estate. You have limited space, you have two catheters in the same place. So I really think that's a good question. So anatomically, when we place venous cannulas, and I mention this because I've realized recently that people do it differently. It's funny how you do a procedure for 5 years and you think everybody does it the same way, and then you talk to somebody about it and you find out they do it very, very different from you. So when I place a venous cannula for ECMO, I go all the way up across the right atrium and place, and remember, I'm coming from the femoral vein. So that cannula goes all the way from the femoral vein up and across the right atrium, and I put the distal tip of that cannula up in the SVC. So I'm actively draining the blood from the upper body through the SVC. I'm draining it from the right atrium with the side holes from the cannula, and then I'm also draining it from the IVC with side holes that extend all the way down. And we use the McKay cannulas here. So if you, I don't know which brand you may use, but it's pretty standard. There isn't a big difference, honestly, I think, between the McKay and Medtronic and other companies that make these cannulas. But functionally, you have an end hole, and then you have a bunch of side holes going all the way down, and it reaches far enough that it goes across the right atrium in all the way to the IVC. Now my ThermoGuard catheter, I run up the other femoral vein and bring it up all the way to the caval atrial junction. So I do not enter the atrium with that catheter. That's important for a couple reasons. One, I don't want any catheters in the right atrium that I can avoid being there, so that I don't tickle the atrium and cause atrial fibrillation or other issues with the atrium. Second, I therefore limit the holes, the side holes of that cannula that could possibly be occluded by the ThermoGuard cooling catheter. Now, I have had a few patients where they're on ECMO and they have a cooling catheter, and they have a lot of what we call chugging, which suggests that the side holes are being plugged by something. Now, the most common scenario for chugging is they're actually being plugged by the combination of the IVC and the SVC clamping down, because the pressure in the vein is so low that as it's pulling all that volume into the ECMO circuit, it sucks the vessels down on it, actually occludes the whole cannula all at once. And the tubing jumps, and it's called chugging, at least that's what we call it. If somebody has a lot of chugging and we're giving them fluid to try to prevent it, and it doesn't work, I have wondered on occasion whether the ThermoGuard cooling catheter could be blocking some of those holes. It can't physically block them all because it's not going far enough to do that. But could it block one or two holes that could make things worse? I have, on those occasions, moved the ThermoGuard cooling catheter it has never fixed the problem, which tells me that it was never actually the problem to begin with. But it has, that same question that you asked has occurred to me multiple times, and it's never been true as much as I've tried, because I really want it to work one of these times. So, but it's never the problem. It's usually just a fluid problem, and I fix it with just more fluid. But in any case, theoretically, I think the question is sound. Theoretically, it could block a hole, maybe 2 holes, but it's never enough to cause a problem, even if it is doing that.
Thank you. Maybe one more questions. I know it's pretty late at your time. I want to respect you.
It's still early for me, so I'm happy.
It's still early to you. I know it's like a 9 o'clock your time. So I know all the ECMO patient that you are using anticoagulation. So actually there's a question talk about ask you what's your anticoagulation regimen. Actually, I add one more question is after you remove the cannula, are you kind of like weighing down the anticoagulation for the cooling catheter or the similar, regimen?
Good question. So good questions, multiple questions. So I will take the last one first, actually. So if I have a patient who does not go on ECMO because they are not an ECPR patient, they are a patient with ROS, and I put that cooling catheter in, I do not routinely give them anticoagulation. So I don't, in my experience, you do not need to be anticoagulated to have a Thermogard catheter in. And therefore, if I take the ECMO out, they no longer have a reason to be anticoagulated in my mind. I'll just turn off the anticoagulation and leave the Thermogard catheter in there to do what I need it to do. So that's with regard to the Thermogard. The ECMO anticoagulation regimen is heparin based at our institution. Some people use bivalirudin. There are reasons to do that to avoid heparin-induced thrombocytopenia or HIT, but there are also reasons not to do it. Again, bival is much more expensive, at least in the United States, so we do not routinely use bivalirudin unless a patient has known HIT. So our patients almost all receive heparin for the anticoagulation regimen. Now, how do you measure it? Also done very differently in different institutions. In the United States, some people use anti-10A levels, others use PTTs. We use ACTs. So we are an interventional cardiology sort of foundational group. So we are very comfortable with ACTs. That's what we use in the cath lab, activated clotting time. And we, for anybody on ECMO, generally use a target of an ACT of 180 to 200. There has been a lot of discussion over the course of a decade or more looking at the different ways to assess anticoagulation in ECMO patients and ECPR patients. There is no clear answer, and I am not a hematologist, but I have talked to many hematologists who will argue for hours about why one would be better than the other, and they argue with each other, which makes me feel good that nobody knows the right answer. So we still stick with ACTs. We have good outcomes. We don't have much bleeding risk. We don't have much clotting risk, and it seems to work for us. But there are certainly institutions that use other ways of measuring and controlling that heparin. I would say, at least again, in the United States, where I'm most familiar with the different models, heparin is probably the dominant way still to determine or to anticoagulate patients on ECMO in the United States, though there are some institutions that do use, again, primarily bivalirudin. But we, again, use heparin with an ACT guide.
How long do you keep the catheter after completion of the cooling?
So I keep it in for at least 48 hours so that I can control fevers and prevent fevers. But even after that, I will leave it in for another 2 or 3 days if I'm using lots of pressor medicine. So if I want a central access, I will leave in effectively the Thermogard cooling catheter to act as a central venous catheter for the duration that I need it for those pressors, and then I will take it out when the pressor requirements have dropped down. Or if it's really late, more than a week, then I may get a central line, just a standard central venous catheter in the neck and use that. But generally speaking, I'll use the Thermogard the whole time.
Okay. I'm going to ask the 2 interpreters, is any questions asked in Japanese you can translate? I don't know if they need unmute.
But
Okay.
certainly we can translate Japanese questions into English.
Okay, is anybody ask you in Japanese? No. Okay, well, thank you very much, Dr. Bartos, for your outstanding presentation. And thank you everyone for participating in this, this actually, I think is a Pan-Asian webinar, because I saw some people from China, from Japan, from Korea. I don't know, I only can read some, the character. So this is turned into really good, like a worldwide lecture here. Dr. Bartos, maybe you have to start learning different language.
Fantastic. Yeah, I'm not very good at languages, so thank you all for being better at English than I will ever be at other languages. I apologize for that. But I really do appreciate you all attending and listening and participating and asking questions. I really do appreciate it.
Thank you. Oh, Australia, they try to make sure I acknowledge from Australia, from Malaysia. So thank you, Dr. Bartos. So with that, I think we are concluded today's presentation. And good night to Dr. Bartos, and good day to the rest of you. Thank you.